Welcome and thank you for joining tonight's Ask the Experts virtual event. Move easier, feel better, expert strategies to conquer your joint pain. I'm Dr. Brendan Patterson, Chair of Orthopedic Surgery at the Cleveland Clinic, and I will be serving as the moderator tonight. I'm joined by a panel of Cleveland Clinic orthopedic specialists. We're here to answer your questions and share insights on smart ways to keep your joints healthy and stay active with less pain. When it's time for joint replacement and what to expect, innovative treatment options including same-day joint replacements and robotic-assisted total joint surgery. And finally, life after surgery, physical therapy, and recovery tips for long-term success. Before we get to our questions, let's meet our panelists. They'll briefly introduce themselves and share how they personally keep their joints healthy. We'll start with you, Dr. Kogan. Please tell the audience about yourself.
Hi, everybody. My name is Charlie Kogan. I'm just starting my second year in practice here at Cleveland Clinic. Completed my residency in orthopedics and a special year fellowship training in shoulder and elbow surgery. So I do everything from fracture care to young patients with rotator cuff tears and especially joint replacement, both primary and revision. One of the ways I keep my joints healthy is by staying active. So shoulders in particular rely a lot on all the muscles around them. So your deltoid, trapezius, pec, latissimus, all these important muscles need to be healthy and strong for the joints to be healthy and strong. So even if you have arthritis, even the little things you can do to keep those muscles strong, find it to be very important.
Dr. Wera, please introduce yourself to the audience.
Hello, my name is Glenn Wera. I'm an orthopedic surgeon at Cleveland Clinic. I specialize in hip and knee replacements. I've been in practice for 16 years. After I did my residency, I did an additional year of training doing all hip and knee replacements. For bone health, one of the things that I do is I go on long walks with my spouse. That counts as a non-impact exercise. And so it's good for your health, but also will minimize impact and wear on your joints. I also recommend working with your primary doctor to get your vitamin D level checked.
And Dr. Harmon, please tell the audience about yourself.
Hi, my name's Dan Harmon. Thank you, everybody, for joining. I've been in practice and coming up on my 11th year. It'll be September, will be starting my 11th year. I primarily do hip and knee replacement and revision hip and knee replacement. I did my residency at Cleveland Clinic and then went on, just as these folks did, to do a fellowship in hip and knee reconstruction in Pittsburgh at Allegheny General Hospital. As far as keeping my joints healthy, always practice good mechanics when picking up our son who's 3 years old. And then as far as I'm a big fan of the Peloton, so just staying active and making sure eating healthy and trying to do something at least 5 or 6 days a week as some type of aerobic activity.
Again, I'm Dr. Brendan Patterson. I've been practicing orthopedic surgery for 33 years. I see patients largely at main campus. My specific area of specialty is trauma and adult reconstruction. And one of the things that I try to do in my daily life is what I would call low impact exercise. I try to get out on a bicycle at least 3 or 4 times a week. And in the winter, I'll use a stationary bike. But I think that combined with, at my age, I find myself very close to the population of patients that need surgery. So I'm very aware of what high loads, repetitive high loads can do to the articular surface, the cartilage surface of our joints. So I try to stay in that low impact zone for my exercise routine. Now it's time to answer your questions. We received more than 280 questions, so we'll attempt to answer as many as we can in the next 45 minutes. The first question that came in from you, I'm going to ask Dr. Kogan to answer. What are the non-surgical treatments for osteoarthritis of the hip, the knee, or the shoulder? And are there any new treatments
So non-surgical treatments rely on a lot of things that some people have tried to some degree leading up to their office visit, though they may not have done it as intently as they might be able to. So these include things like activity modification, rest, ice and heat. A lot of patients ask, what's better, ice or heat? Truth be told, I think they're both helpful. General rule of thumb that I give people is ice to cool off and heat to warm up. So if you're going to do some exercises, maybe use a heating pack before you get started. Treat it as a warm up. When you're done with your exercises, that might be a good time to throw an ice pack on. Other important modalities for non-operative management of joint pain include non-steroidal anti-inflammatory medications. This includes ibuprofen, Aleve. Those are examples of a couple over-the-counter. There's also prescription strength NSAIDs, meloxicam, Celebrex. Lastly, physical therapy. So I alluded to this in my introduction, but really important to keep the muscles around your joints strong as well. This is particularly important in the shoulder, where things like the rotator cuff play an important role in the development of arthritis as well. So those are some of the non-operative modalities that people utilize. Injections are another important one. So most commonly, people think about steroid injections. This is usually a combination of cortisone, lidocaine, and this is something that can be repeated generally every 3 months because it provides symptom relief for patients. Certain joints, like the knee, for instance, do well with another type of injection called viscosupplements. That's something like hyaluronic acid, which might actually be a series of injections. But that's not good for all joints. So in the shoulder, for instance, that doesn't actually provide meaningful relief for people when you look at study populations as a whole. So those are some of the classic non-operative therapies. There are some more emerging modalities. A lot of people hear about stem cell injections or platelet-rich plasma injections, but these don't have as much of a robust amount of evidence to support them. They tend to be costly because they don't have a lot of evidence. Insurance companies are not as willing to pay for these. So a lot of times patients, if they do decide to do this, may have to pay out of pocket. So those are some of the new things. And I think a lot of advancement has been made in the way of surgical treatment of joint pain in the last decades.
Thank you, Dr. Kogan. Dr. Wera, when do you know it's time to replace a joint, and can patients wait too long?
In my area, I'll usually see patients who have hip and knee replacements. And not always, but frequently I find that people will usually try about 3 different modalities before turning to surgery. And by no means is that a rigid rule, but it seems to be a general recommendation of many non-operative providers before a patient will see me. And so those things might be, as Charlie mentioned, an injection, therapy, or anti-inflammatories. When those treatments are not adequate any further, it's appropriate to start thinking about surgery. And in some cases, we do see people who have waited quite a long time, and the severity of the arthritis has advanced to the point where the operation may be more complex or longer. And typically, I will inform the patient of that maybe their case might be non-standard or that may require additional time or equipment to do the surgery. As the patient, a way you might know this is if you have significant difficulty walking, going to the bathroom, and performing your activities of daily living.
Thank you, Dr. Wera. Specialization is a reality in healthcare today. Dr. Harmon, how do you determine which physician to see when you have spine, knee, and hip pain, since doctors are so very specialized today?
I could understand where this question is coming from because we are getting more specialized over the years. And I think a lot of this is dictated initially by your primary care doctor. So, they're kind of the quarterback of your care overall. And sometimes, if you go in with all 3 of these things, they'll order hip, knee, back x-rays, and then probably refer you out. And I think that there's such an overlap between all of these different symptoms. So the spine can affect the hip can affect the knee. And there's many times that we see people with knee pain that come in, their x-rays look great, their knee exam is normal as far as knee pain goes, and then you examine their hip, and this affects their knee. So a lot of times the hip is what's causing the knee pain. And this is from arthritis or from a nerve that gets irritated in the hip, and it can radiate pain down to the level of the knee. So there's a large overlap between all of these symptoms. And I think at the end of the day, the best way to do this is to come into a hip or knee specialist office. I mean, it's 2 out of the 3 things that are hurting you, because obviously hip, knee, and spine, there's a huge overlap. And I think if you come into a hip and knee specialist, that's our job, is we're going to figure this out for you and do the best that we can to determine exactly what your pain source is. And, you know, if you come in and it's not the hip or knee, we're going to refer you and get you into the right folks in order to take care of your spine. But all of these things are interrelated. And there's many times people come in and point more to their gluteal area and say, you know, my hip's killing me. And a lot of times that's more back. But that's our job to figure that out for you and diagnose you and get you moving in the right direction and get your treatment plan organized for you.
So, Dr. Wera, cartilage is a living tissue. Osteoarthritis is a wearing away of that cartilage. Can you regrow cartilage in your knees?
This has been a focus of a great deal of research in orthopedic surgery and in basic science. And in the setting of the conditions that I most typically treat, which are inflammatory or post-traumatic arthritis, it's not possible for patients to regrow cartilage in any meaningful manner. There are some cases where there are small focal areas of injury that can be treated, and the cartilage that grows back is not the same as your native cartilage and is more of a scar tissue type cartilage and will not be as functional and meaningful. So the simple answer is no, but there is research in this area. And in some specific focal areas, there are alternatives such as cartilage grafts, et cetera, or procedures that can cause a scar-like tissue similar to cartilage to grow. But by and large, it's not possible for older patients with arthritis.
Dr. Kogan, how can you distinguish between muscle pain, nerve pain, or joint pain in a particular part of the body?
It overlaps a little bit with what Dr. Harmon was talking about, in that it's not always clear. And you may have a lot of overlap actually between these things. And pain in your joints can masquerade as pain in the muscle and vice versa. So a common one for shoulders is that even deep-seated shoulder pain can radiate down toward the elbow, even if the elbow is totally fine. I would say by and large, muscle pain and joint pain have the most overlap. Patients tend to report a sense of achiness, especially with osteoarthritis. It's something that feels more stiff and painful in the morning. As your day goes on, you go about your activities of daily living and you use those joints, they actually loosen up and feel a little bit better. One unique thing about the shoulder is that regardless of the cause of shoulder pain, whether it be rotator cuff problem or arthritis in the shoulder, it tends to be painful at night. I think that's because people sleep on their shoulders and may sleep with their arms overhead, and that's a common complaint as well. Of those types of pain that were mentioned in the question, I think nerve pain probably stands out the most, because nerve pain, although it can present in different ways, I would say it most commonly presents as sharp, searing, burning, shooting. Those are some of the adjectives that patients use to describe it. And it can even, especially in regards to the shoulder and the neck, can usually start in the neck, and patients say it radiates down all the way down to the fingertips. And if you're getting pain that goes down into the fingertips, that can most commonly be caused by nerves, particularly nerves coming from the neck. And that's the job of your surgeon, whether it be an orthopedic surgeon or a spine surgeon or any of your treating physicians, to help try and diagnose that and point you in the right direction.
And the question that I fielded to answer, what is the role of stem cells in treating joint disease? We sense that stem cells, at least in theory, are the holy grail of managing parts of our bodies that are worn out. For those of you that are not fully aware of what stem cells are the cells that have not yet differentiated into skin, muscle, bone. They're the initial cells that the body makes to repair everything in and around the human body. And the stem cells, we hope at some point, if we can refine the technology, can be used to replace some of the damaged cells, not only in the joints that we're talking about this evening, but in the kidney, in the heart, in the liver. But right now, the stem cells that we're using, the science is not yet completely evolved that we understand their role. It is very popular in some segments of the healthcare industry to offer stem cell treatments. We do feel there's a role for some select cases, but the technology is not quite refined to the level that we see this as reliable as some of the more conventional treatments for osteoarthritis. Dr. Harmon, what is the current preferred approach for hip replacement, front, side, or back, and what do you prefer?
I think the most important thing to say here as far as a hip replacement is concerned is a hip replacement is a good procedure, regardless of the approach. I think there's not a lot of things that we could say in medicine that we're typically getting A's on routinely, and I think hip replacement is one of them. More traditional approaches are through the back or through the side of the hip, or that's the way it's traditionally been done over the past several, probably decade at least. The approach that's been more popular is called the direct anterior approach. I think the most important thing is that you're comfortable with the surgeon and you're comfortable with whoever's doing it, and that he or she and the patient had a good discussion about the hip replacement, the risks and benefits, and that's the most important thing. And I think the preferred approach is the surgeon's preferred approach. As far as the approach that I use a direct anterior approach. I've been using that since I've been in practice over the past 11 years. I think that there is some evidence and clinical studies to suggest that there is an earlier recovery period. I think that the first 6 to 8 weeks, I think by 3 to 4 months, you probably can't tell which way you did it. But the most important thing is being comfortable with the person performing the surgery, and the preferred approach would be whatever approach that surgeon uses.
What is a hip revision, and when is it something to consider?
So there's a metal piece that sits in your socket. There's also a metal piece that we put down the femur bone or down the middle of the thigh bone. There's a ball that sits on top of that stem. In between, there's a plastic piece that could wear out over time. Industry and orthopedic surgeons have really focused on making that bearing wear at a much lower rate than it has in the past. So what happens when that polyethylene or that plastic wears down is that it could create debris, and that debris can eventually lead to us needing to do a hip revision. Now, a hip revision can consist of something as simple as going in and changing the plastic out that's inside the hip joint, or it can consist of taking the entire hip out, including both the piece in the socket and the piece in the femur or thigh bone. Depending on your symptoms and depending on the pain that you're feeling, and also how long the hip replacement has been in there, is going to determine exactly what we need to do for that hip revision. I personally follow all of my patients every 2 years after a total hip replacement, after their initial follow-ups. Number one, to get an x-ray and make sure that we maintain those x-rays, and also to discuss if any of those symptoms are happening. So I think it's a complex operation. There's many different factors that go into it, but at the end of the day, it's something that needs to be managed by the surgeon with close follow-up every 2 years after your initial primary total hip replacement.
Thank you, Dan. Charlie, you nicely described the different sources of pain, specifically around the shoulder. How do you determine the origin of pain when people describe it as in their neck, their shoulder joint, the shoulder blade, sometimes in the chest?
I think a lot of it goes back to just listening to the patient. Like I said, a lot of pain coming from the neck, from your cervical spine. Patients will describe that as sharp shooting pain that goes all the way down their arm, all the way into their hand or into their fingertips. And to me, that's a red flag that there might be something that's not just the shoulder that's going on, but it might be involving the neck as well. There are different maneuvers and things that your physician might do in the physical exam when you're in the office so that they can test specific muscles. They can test the shoulder or the joint in particular positions to try and elicit some of that pain. So the physical exam is a very important part of this decision-making process as well. Every now and then, people can still be a little bit stumped as to where the pain is coming from. And so we rely on imaging as well to help us out. MRI scans can be obtained, CT scans can be obtained, even just some regular x-rays, whether it be of the shoulder or the neck. And lastly, there are tests to look at nerves as well. So there's something called an EMG, and that is something that you can look at see how the nerves are responding to different stimuli to see if there's anything to suggest some injury to the nerves. So by and large, I would say it's mostly from the physical exam and from listening to patients, but there are a lot of other tools that your physician might use to come down to the diagnosis.
Glenn, what can patients do before and after surgery to recover most effectively, specifically to reduce swelling and prevent scar tissue after surgery?
First and foremost, it's necessary to optimize any medical problems you might have. If you do have health concerns that cause swelling or edema, it's a good idea to have those issues addressed first. That can be by seeing your medical or heart specialist to work with you on optimization of your fluid status and any swelling. Many patients suffer from chronic swelling in addition to osteoarthritis, and oftentimes the use of sleeves or hose can be helpful. And if you have those already, you should use those before the operation. Oftentimes, it will provide you with a set after surgery as well. In terms of prevention of scar tissue formation, that's always been a challenge for not just orthopedic surgeons, but surgeons all over the world. And in terms of range of motion of your knee, there's an old adage in our field that says your preoperative range of motion will dictate your postoperative range of motion. And it goes back to one of my earlier points about knowing when you've waited too long or if surgery is indicated. If you feel like you're losing range of motion already, it may be time to consider the timing of your operation on the sooner side than later, because the body will tend to habituate your arc of motion with your joint.
And now I am pressed with the question, what are the advantages of robotic total knee replacement versus traditional replacements? I think the audience needs to understand that the components that are used for robotic surgery and traditional knee replacement are the same. The robotic surgery is developed or designed, configured to assist the surgeon in perhaps more precise placement of the components. So the components are the same, robotic or not, but it's the placement and the insertion and the bone cuts that the robot provides some assistance and guidance. I will admit to the viewers that I was a skeptic of robotic knee replacement, and it took me a while to understand the benefits. I think the benefits of robotic knee replacement is that there is a finer sensitivity, a little bit more precision in placing the components so that the knee is balanced. By balanced, I mean the ligaments in the knee are at their appropriate position that permits the knee to move as it's designed to move. I also think there may be a little bit less pain with the robotic knee replacement because there's a little bit less retraction required, because the surgeon can guide the blade in a way that it doesn't escape the periphery of the bone. So the blade in a traditional knee replacement can sometimes go out and touch the soft tissue. In a robotic knee replacement, that's less likely or less common to happen. I think the outcomes are very similar between the two. Dr. Harmon, is a same-day hip or knee replacement realistic for all patients?
So I think in medicine, anytime we say all, we got to be skeptical of that. So I don't think that all is a fair statement. I think that obviously we're doctors before we're surgeons. We have to look at the whole person. We have to look at all the medical conditions, the overall social environment, how many stairs do you have in your home, is a multi-level home. All these things come into play when we talk about going home the same day. And it also we also talk about some of the things that Dr. Ware alluded to as far as your preoperative motion, your strength, what overall activity level are you at now? Are you walking with a walking aid? So all of these things go into the decision-making process of being able to send somebody home the same day. And I think that the medical doctors are involved, and it's certainly a team effort with anesthesia and a multimodal pain management program afterwards. So there's a lot that goes into that decision-making process. For example, we send home approximately 80 to 85% of our patients the same day, but we also do an extensive pre-surgical workup to make sure that patients are ready to do that. So we have them in preoperative physical therapy. We make sure that they see a medical doctor prior to get cleared for the operation. So there are a lot of things that go into that, but to say all, I think is not true, but I think that roughly 80 to 85% of patients are able to go home the same day.
Dr. Kogan, is there a way to reduce shoulder and neck pain without surgery? Steroid injections, pain medications, what are your thoughts?
There are a lot of effective non-operative modalities. And like Dr. Ware said, a lot of patients have tried these out before they have made their way into a surgeon's office. But there are some patients that a surgeon never meets because patients do get long-standing relief from these non-operative things. Going back to a common theme that a lot of people have mentioned today is the importance of staying active, the importance of maintaining flexibility in your joints. And I think if patients can get this through physical therapy, through a home exercise program, maybe taking occasional medication for the pain, such as ibuprofen, Tylenol, some patients can get meaningful, lasting relief. However, arthritis is a degenerative condition, and it does not necessarily slow down. It just advances as you get older. So I think it's important for patients to realize that there's really no way to halt or stop arthritis from occurring. As long as symptoms are manageable for a patient, they can probably have a very satisfactory outcome without surgery. But the patients who I find are most happy with surgery are ones who feel like they've exhausted all of the non-operative options presented to them so far, and they truly feel, they and the surgeon feel very comfortable moving forward with surgery because they know they've exhausted all of the other options.
Glenn, are most total knee replacements performed due to arthritis? Is there any difference in recovery if done for other reasons?
Rarely, knee replacements are performed for conditions such as severe fractures, tumors, or non-unions of fractures. And those are more emergent conditions and not really the subject of this webinar. Most of the patients watching this and most of the patients who see me are considering an elective joint replacement, and that is indeed for some form of arthritis. There are three major forms that we treat: osteoarthritis, or the wear and tear arthritis that many patients have; inflammatory arthritis such as rheumatoid arthritis; or post-traumatic arthritis. Maybe you've had a fracture in the past years ago and have now developed problems with your joint since then. The path for each of those three conditions is different. We do see very high rates of satisfaction for patients with inflammatory arthritis. So if you have rheumatoid or psoriatic arthritis, the pain relief of the operation for patients can be so complete that they're oftentimes surprised at how well they do after the operation. And this has sort of been an adage in our field going back probably to the 1980s. Most of our patients have knee replacements or hip replacements for osteoarthritis, and that's sort of the wear and tear arthritis that people most commonly see. Outcomes are predictable. Most patients see pain relief. The time to recovery is 6 to 12 months. And then finally, for that third group of patients who have knee replacements or hip replacements for post-traumatic conditions, sometimes the courses for those can be a little bit less predictable, and I'd consider them a special case and not really appropriate for a general statement.
Appreciate that input, Glenn. Now back to me. Does a partial knee replacement mean you will eventually need a full replacement? And how does one decide which is needed, a partial or a full? The way I look at this is the knee has three compartments: a medial compartment, which is in the inner part of the knee, where you would run down the inside part of your thigh; a lateral compartment, which is the outside, where your pocket is, down by the knee; and an anterior compartment where the kneecap is. That's in the front part of the knee. For me, I will consider a partial if the plain x-ray shows only medial compartment arthritis, and when asked, the patient can say or point to that part of their knee that hurts. So if I ask someone with an x-ray that has one compartment that's bad, the medial compartment, and I say, where does it hurt? And they can take their finger and point exactly to the side of the knee and nowhere else, I will consider that patient for a partial. Partials hold up pretty well if done in an expert fashion. The progression of the arthritis in the other compartments may warrant a full knee replacement later, but the hope is patients get 10 to 15 years of high function from a partial knee replacement. Dr. Harmon, patients who've had one hip replacement, what are the odds that that patient will need to have that hip replacement redone?
So as far as that hip replacement redone, I always tell patients it's a 1 to 3% chance of a complication happening during a total hip replacement. It's 100% if it happens to you. So as I said at the very first question, I think, 97% of patients, when we talk about the forgotten score at 1 year, does your hip feel normal? Normal being defined as the fact you never think about the fact you had a total hip replacement. 97 out of 100 people say completely normal. As far as if somebody's going to have the other side done, so if you have one side done, what are the odds of you having the other side done? There's been multiple studies of this and looking at Swedish registry, Australian registry. We also did one at the Cleveland Clinic in 2019 that looked at the odds of having that other hip replaced. So, and that odds are roughly 25% at 5 years. And at, I believe it was 8 years, it's roughly 30%. And that goes for both hip and knee on average. That includes just osteoarthritis or degenerative arthritis, run-of-the-mill wear and tear. As far as other conditions in the hip, if it's avascular necrosis is a condition which is basically a decreased blood supply to the ball and socket joint. And if that happens, many times that is on both sides or bilateral. So those people end up having to have both hips replaced at a higher rate than somebody with just degenerative arthritis. But as an overall rule, it's 25% at 5 years is what the data shows us.
Glenn, we truly hope all of our patients just are completely pain-free after surgery, but we do face situations where people struggle after a knee replacement. What should patients do if they're still feeling pain in their knee after it's been replaced?
Persistent pain after a knee replacement is actually a common question and a common challenge for patients. I think first and foremost, the timing of the persistent pain after the surgery requires patient counseling. What do I mean by that? If you've had your knee replaced in the last year, it's important for you to know that some residual pain can be possible for up to a year after surgery. However, if it's accompanied with associated symptoms of infection or instability, or you feel like you're losing range of motion, you should bring that to your doctor's attention. There are significant complications or concerns after a knee replacement that your doctor or we can work with you to evaluate before taking the next action. Laboratory values and imaging are all relevant.
Dr. Kogan, are there any causes for shoulder and arm pain that are commonly overlooked by physicians?
One of the unique things about shoulder arthritis is that we mentioned today osteoarthritis, we mentioned inflammatory arthritis, we mentioned post-traumatic arthritis, which is if you've had a fracture or a dislocation or something like that. But a very common cause of arthritis in the shoulder is actually the rotator cuff, and that's pretty unique to the shoulder. So the rotator cuff helps keep the ball centered in the socket when you're moving the shoulder around. And if you have a tear in the rotator cuff, this can lead to asymmetry of the joint when you're trying to move it. It's like driving around in your car if the lug nuts on your wheel are not tight. So things are loose and rattle around. It can lead to arthritis. And so I think there's a lot of overlap in the shoulder in regards to arthritis that is developed because of just wear and tear from the cartilage in the bones, which would be osteoarthritis, and because of rotator cuff tears. Again, we mentioned today a lot about the difference in the overlap of symptoms, whether it be nerve pain, muscle pain, bone pain. So I would say probably some of the most commonly misdiagnoses when someone's referred to my office for shoulder arthritis is that they may actually have a rotator cuff problem, or they may actually have some cervical spine problem leading to pinched nerves in the neck that lead to shoulder pain, arm pain, hand pain, etc.
Glenn, can a patient who has diabetes get a knee replacement? Isn't there a higher risk of infection?
Like all medical conditions, diabetes is one of our concerns around the time of surgery. If you're thinking about having a hip or knee replacement and have diabetes, it's important to review that with your surgeon and your primary doctor who's managing it. Control of your blood sugar both before the operation, around the time of surgery, and after surgery are key things that you can do to prevent infection. Most patients who have diabetes are familiar with following their blood sugar with a value called the hemoglobin A1C. Initially, values of 8 or less were considered optimal for surgery. However, it may be necessary in some cases to tailor the optimal number for you based on the severity of your diabetes. In general, the lower the hemoglobin A1C, the better. However, there can be some special considerations. Most patients at Cleveland Clinic won't be having an elective joint replacement with a hemoglobin A1C over 8, but oftentimes your surgeons will ask you to work on getting that number as good as possible before proceeding with the operation. Even when the number is ideal, the risk for infection is higher, and that's probably our most feared or deepest concern when considering a joint replacement.
Why is infection such a concern, Glenn?
The reasons for that are the management of infection around a joint replacement can be a challenge both for your body to fight and for our medications to penetrate. And so oftentimes it will result in additional surgery as well as medical treatment, and can involve extending the amount of time it will take you to recover from that. The rates of this are low, but it's serious. And if you're concerned that you have a joint replacement infection, you should have that evaluated with an orthopedic surgeon.
Dr. Harmon, can you have a hip replacement if you live alone?
Absolutely. The answer to that is yes. And this kind of goes back to the previous question as far as going home the same day if you live alone, or can everybody go home the same day? So if you live alone, certainly if you have hip pain and you have hip arthritis and you meet the requirements for a total hip replacement, you could certainly have a total hip replacement. Now, that being said, it also depends on, do you have somebody that could come into town to help you? Do you have the resources and the people around you that could also provide help at home? If that's the case, potentially you could go home the same day. If it's something that you don't have anybody around, or you don't have anybody to come over that same day of the hip replacement, then it would be something where you stay in the hospital. I tell my patients, you could stay a day or two in the hospital, and if you feel good enough, then certainly we could get you home, and we would have home health care come out and work with you for the first couple of weeks after surgery. If there's the need for rehabilitation, our adult reconstruction team, our hospital team, our social workers would work with you and get you into a rehab facility for a certain amount of time until you feel safe enough to go home. But absolutely, everybody's going to make sure that you're safe to go home initially, and nobody's going to ever have you go home unless you're able to do the things that you need to do to be safe in your own home if you live alone.
Dr. Kogan, what, if any, are age limits on surgery? And can you be too young?
The question that usually gets asked is, can I be too old for a joint replacement? And I think the answer to both those questions is, generally age is just a number. And so we look at all sorts of patient-related factors when we're discussing whether or not a joint replacement would be an appropriate surgery. Generally, as patients get older, things that we consider are your ability to recover from surgery, your body's ability to withstand surgery, so whether it be serious heart conditions or lung conditions. And these are all things that we evaluate very closely with the help of our anesthesia colleagues, cardiology, your primary care doctor. So these things all get thoroughly worked up before any patient undergoes surgery. Very rarely, but every now and then, there are patients who are too sick to undergo surgery, and that's a serious discussion that needs to be had with the surgeon and the entire team. But that's very rare. The question about whether or not you can be too young for a joint replacement, I think, is a very good one. Everyone in the audience should remember that a joint replacement is a mechanical part. So what I always tell patients is, just like the person who slams on the gas, slams on the brake between every stop sign, is going to wear through their brakes, parts of their engine faster. So is a person who puts a lot of wear and tear through their shoulder replacement, or any of their replacements for that matter. So I do think it is especially if you're a very young patient, it becomes a balancing act, understanding what is the quality of life currently that you have. Will a replacement, understanding the risks and the rate of likely needing a revision surgery. If you undergo your primary replacement at a young age, odds are you will outlive the joint replacement. So these are all complex series of factors that you and your surgeon will discuss and should discuss in great deal before deciding to move forward with a shoulder replacement, knee replacement, hip replacement, any of these.
That's a great response, Charlie. And mine builds on that in the sense of the question that I've been posed is, do replacements ever need to be replaced? The answer to that is yes. Sometimes that replacement, that second replacement operation, can be as simple as changing out one of the bearing surfaces, usually the plastic. There's a polyethylene plastic liner that sits between the two metal pieces in a joint. Sometimes those wear out over a long duration, and as Dr. Kogan indicated, how the joint replacements are used will impact how long they last. Can you break a hip or knee replacement? Hard to break the replacement, but you can easily break the bone the replacement is in. And as we face aging and our risk for falling, I'm very clear with patients that they have to be mindful as their balance weakens as they age. They have to have a low threshold to go to an assisted device to prevent a fall, because a fall in which a joint replacement component breaks free from the bone can be life-changing. Dr. Wera, does hip and buttocks pain that prevents you from sleeping or lying on your side mean that you need to see a doctor?
If you have concerns of that nature, it is appropriate to see a doctor. However, it doesn't automatically mean that you need a joint replacement. Frequently, I see patients with pain radiating to the upper buttock, and that could actually be coming from the lower lumbar spine, and there are many excellent non-operative treatments for that. By the same token, pain on the sides of your joints can be referred to issues such as tendonitis or bursitis, and those also can be treated non-operatively. However, a thorough evaluation with an examination and imaging is necessary to determine whether or not it's an arthritic condition that would lend itself to joint replacement, or if something else is needed.
Why does a patient's hip or knee hurt or lock up when trying to walk, stand, or get up from a seated position?
Locking and clicking can be common symptoms of arthritis, and oftentimes what the patient is sensing in those conditions is the engagement of the bone spurs from one bone or the other. For example, from the femur onto the socket of the acetabulum, or likewise from the femur or the top of the tibia on their knee. If you're feeling this, it speaks to the fact that the arthritis may be severe and additional evaluation such as x-rays is necessary.
Dr. Kogan, does the quality of the bone influence your surgical decision?
A lot of patients ask this, especially patients who may have a diagnosis of, say, osteoporosis or osteopenia, patients who maybe have a history of taking oral steroids like prednisone for a long time, perhaps have advanced chronic kidney diseases. This is something that a lot of patients are concerned about, and they ask if joint replacement is still possible. And the answer is yes. There are things a surgeon might do during the surgery to either increase the size of the components or the length of the components to get a more stable replacement component into the bone. In the shoulder, there's also two different types of replacements. There's an anatomic replacement and a reverse replacement. Both are very good operations, and certain patients do better with the standard replacement, and certain patients do better with the reverse replacement. Particularly in the case of poor bone, because of one of these things that I've already mentioned, that may be a reason that your surgeon decides to proceed with a reverse shoulder replacement.
And we are just at the top end of our list of 280 questions. We have time for one final question. Dr. Harmon, what is the best therapy to keep up years after surgery to maintain the function of the hips and knees that are replaced?
I think this kind of echoes everything that, we've been talking about as far as staying active. When people get joint replacements, we want to decrease pain and improve function. That's our whole goal as orthopedic surgeons. And I think when it comes to overall, even preoperatively or postoperatively, I tell all patients with arthritis or after I replace their joint, non-impact loading exercises is the best thing to do for your joints, or to continue to move. And I recommend bicycle, elliptical, swimming. Now, clearly, if I was in practice in Florida for 8 years, so everybody likes to go on walks down there. That's clearly a non-impact loading exercise. But whatever it is that you get out and do every day with your family, your kids, whoever you go out and have activities with on a daily basis, to stay active is the most important thing. There's no specific therapy that I think that I would suggest to do. I think at 1 year where you are after a total knee or a total hip replacement is kind of where you are and how that joint is functioning. But to continue to stay active is the most important thing, I believe.
Thank you, Dan. That was our final question. Thank you to our panelists, Dr. Harmon, Dr. Kogan, and Dr. Wera, for your expertise. The orthopedics department at the Cleveland Clinic is proud to be recognized in the United States and throughout the world for our expertise and our care. Our goal is to help you maintain healthy joints and, whenever possible, avoid the need for surgery. However, if surgery is necessary, our staff performs over 10,000 total joint replacements each year, a volume that's among the highest in the United States. Before the end of the week, you will receive an email with orthopedic and joint health resources, details on how you can make an appointment, and a link to a recording of this event so you can view it again. If you have any questions, feel free to call us at 216-444-2606. We appreciate your time, and we thank you for watching.